Dr. Buffy Lloyd-Krejci. I'm an epidemiologist and the founder and CEO of IPC Well, and we provide dedicated infection prevention and control support to long-term care primarily, and also other underfunded and resourced healthcare settings. So we're very passionate about this work and being able to reduce infections along with harms associated with those infections. And so I was asked, we do a lot of work with Superior Health. I'm sure many of you may have had us come on site or may continue working with us, and we're always happy to be able to do that to support you in your infection control program. And so, you know, we know that enhanced barrier precautions is a really significant topic that as the new guidance from the CDC came out in July of last year, it really created a lot of noise in our industry. And so we've done many presentations on this as well. And so we thought that it was important to continue to do another presentation on this as well. So let me just share my screen and we'll get started. So our objectives today are, like I said, we're going to discuss the new CDC's enhanced barrier precautions and the recommendations, and really talk about the why behind what this is all about. And then we're going to discuss really how it may apply to our federal regulations, and then discuss some best practices for implementation. Now, and Jenna, correct me if I'm wrong, but I don't love being just the one talking the whole time. So I will, or I love talking, but we want interaction. So please interact with us in the chat, Jenna. I don't know if people can come up with it all, but I think probably with the number we'll interact in the chat. And you know, we want to know about your experience. We want to know how you're doing with this, and really have this interactive participation with our call today.
Absolutely. And Dr. Buffy, you're coming in and out a little bit garbled today. So I don't know if it's the microphone on your end, but it's better, I think, if you're closer to your computer. So
yeah, it could. Let me know if it's worse. If it doesn't fix, then Jenna, I'll have you run the slides. That may be the problem. Is it still happening?
A little bit.
Do you want to run the slides then? That may be the problem.
Okay. Let me go ahead and see if I can. I think I should be able to do that, right?
Yeah, let me stop sharing. That sometimes happens. And then if you can share, then I'll just have you run the slides for me.
Okay, well,
sorry about that.
Yeah, let me get your slides up if you want to continue the conversation. I'm doing
okay,
that.
Sorry. Yeah, unfortunately, this happens sometimes with this computer. All right. I just shut down a few things.
Okay. I will go ahead and share now, Dr. Buffy.
All right. Is that better? Can you hear me better now?
A little bit, not great.
Really?
Yep.
Okay. Let's see if we can do something.
So maybe it's just, I think where you're at, if you sit kind of close to your computer, I think it's better.
Yeah, how about that?
Perfect.
Okay. Well, please stop me if I start to come in and out again, and we'll fix it. I don't want to be garbled at all. So.
All right, I will go ahead and share my screen, and I'm going to minimize you just 1 second. So.
All right. Thanks, you guys, for your patience. This is real world, right?
Yep, there we go. So you are up, Dr. Buffy. I have your slides up.
Okay, I don't see them. You'll have to share your screen. If you have another monitor, you may be, yeah, there you go. Okay.
I am singly monitored today, so.
Okay. Okay.
Right.
Sounds good. Can you hear me better?
Yes.
Okay, great. All right, so we'll go ahead and go on to we'll go on from here. Yeah. Okay, so we talked about like what we're doing, and so let's jump into this. Let's jump into this topic and start, talking about how we can implement these best practices. All right, next slide. Okay, so as an infection preventionist myself and an epidemiologist, it's always very important for me to talk about the why. And I really believe that this topic is absolutely no different. When we look at why we're implementing enhanced barrier precautions, it's really due to the increase of antimicrobial resistance. And, this is why we have our antibiotic stewardship programs. And this is why we're working on those appropriate prescribing practices. And, sometimes it's hard to get out of our current facility and really look at the bigger picture. And it's really important that we understand not only the impact we have within our own facility, as well as how that impacts our community, our state, as well as our entire globe. And so antibiotic resistance or antimicrobial resistance, it is considered an urgent global public health threat. You can see here the numbers that estimated 1.27 million people are dying from this, from the resistance, and that 5 million people deaths occurred alone in 2019. So you can see the global impact of it. And, we live in a day and age where we are so fortunate to have the antibiotics, the antifungals, the antivirals that we do have. And we want to make sure that they continue working long into the future. And so the resistance patterns are what are contributing to many of our resistant bacteria and fungus infections. And so that's why we're really working on ways within our industry, within long-term care, that we can reduce the risk of the associated infections that can occur due to the antimicrobial resistance. Next slide. And so just a couple definitions and terms. We define multi-drug resistant organisms. A lot of times we say it is MDROs. That refers to bacteria or fungi that are resistant to multiple antimicrobials. And so that's really what we're referring to here. And then colonization can often be a confusing term for people. And what that means basically is that the germ is found on somebody's body or in their body, but it's not causing an infection. And what's important to note is that even if you're colonized, it is possible to spread the bacteria or fungi. And that's really important to understand. And that is going to be part of the reason why we are implementing enhanced barrier precautions. Next slide, please. And so this all came about, utilizing enhanced barrier precautions through research. And that's important because we want to make sure that the practices that we put into place are evidence-based. And that means that research studies have demonstrated the need for the prevention practices. And so this study demonstrates that when a long-term care facility, there was an actual MDRO that was documented. So, when your residents come to your facilities, it's documented that they have an MDRO colonization, or not. And so you see here that when prevalence testing was conducted on these residents in this facility, what was documented, 17% of them had an MDRO that was documented, but then and 20% in the ventilator unit. What's interesting then is when they actually tested them for an MDRO, you see that over 50%, about 60% of the residents actually had an MDRO, and 76% that were on the ventilator had an MDRO. And so this demonstrates that we're really missing a lot of those colonized cases by simply relying on what's documented. Next slide, please. And another study in 2017, this is probably one of the largest studies as far as, or I would say one of the most significant studies that really prompted the CDC to start talking and having conversations and moving towards this enhanced barrier precautions. And you see here in March 17, there was an outbreak of Candida auris in a nursing home in Chicago. Have any of you guys read this study before? If you have, I'd love to see it in the chat. Are you aware of this study? And so what they showed was they had this positive case, and they showed that one person had Candida auris. And so this is considered an outbreak, right? Because one case is considered an outbreak. So then the Department of Public Health came in and they did screening and testing. Next slide, please. And what we find is that after testing, there were an additional 28 residents for a total of 43% that were positive for Candida auris. And I mean, to me, that like stops me in my tracks, because it's like, okay, so clearly we're missing a lot of what's going on here. Next slide, please. And so, as you've seen with the research, there is a challenge with detecting our multi-drug resistant organisms due to colonization mostly. And so I love this slide and I love this picture because it really depicts what's occurring in our long-term care facilities. So what we're actually seeing that's documented versus what's actually occurring in our facilities is we're missing a significant reservoir of residents that are actually transmitting different MDROs, or are, that are colonized with an MDRO that may be transferred then on the resident, the staff hands, clothing, the environment. And so this is this is kind of why we're doing what we're doing, is because I like to call it's a silent spreader. We don't have the documented cases. And so we have to do something, right? We need to have a way to protect our environment, protect our residents, and prevent the spread of these multi-drug resistant organisms. Next slide, please. And so, as we discussed, the challenges with detecting the MDROs is that there is an estimated 50% of nursing home residents may be colonized with an MDRO. And we do know that most MDRO outbreaks are occurring in the nursing homes. So we have different challenges within our healthcare setting though, right? Because in the hospital, if a patient has an MDRO, the course of isolation is for them to stay in their room until they're discharged. Well, we can't do that in our environment, because the residents potentially could be restricted to their rooms indefinitely. And we can't just focus on active infections, because as we've seen with the research, we know that that is not sufficient in actually addressing that silent spread of the colonization. And so, in addition, we know that MDRO colonization can last for a really long time. So this is why we have to take different preventative measures. Next slide, please. Candida auris, C. auris, is one of those emerging fungal pathogens that, like I demonstrated in the slide, is that, or in the research, is that there is this pathogen is now spreading across the country, and it's in many states nationwide. It does tend to be drug resistant, and those individuals that are colonized do have the risk for invasive infections. So the research demonstrates that up to 10% of people that have a colonized case of it will develop a bloodstream infection within that year. So it is really imperative that we do everything that we can to reduce the risk of spreading this pathogen. Next slide, please. And so just as it's not all about Candida auris, obviously, it's all the multi-drug resistant organisms. Given the emerging, and just that this is an emerging pathogen, I wanted to provide you with this information. And it's not just Candida auris, but if you have any MDROs that you're challenged with, the CDC is a great site to be able to go and identify basic prevention practices within your healthcare setting for many of the MDROs. And I just wanted to bring that to your attention so that you have this resource in your back pocket if you need to conduct more education or training or need information for your facility. Next slide, please. And so, as we discussed, there's a new approach that the CDC is recommending for the usage of personal protective equipment with these multi-drug resistant organisms. And this is so that we can continue to actively work towards reducing the spread of MDROs without isolating the residents for a significantly long time. Next slide, please. And so, as I mentioned, this guidance, the implementation guidance, actually came out July 12th of last year. There have been different iterations of recommendations for enhanced barrier precautions. Many of you may have already been implementing a type of enhanced barrier precautions before this came out, and that specifically was more towards like the emerging pathogens and not necessarily all of the MDROs. And so this was an update where it was more than just the emerging pathogens like Candida auris or CRE or some of those more dangerous, MDROs as well. And so the guidance for this basically was expanded, and that was expanded to include basically utilizing personal protective equipment. We're going to talk about exactly what the recommendations are for residents that are high risk, and that continues during the duration of the residents in their stay. And it does look significantly different than if somebody were to be isolated in their room. Next slide, please. And so who does this apply to? So we want to, and first of all, these slides will be available. I think they're in the chat, and we encourage you to download the slides. I encourage you to go to the CDC website, download the actual guidance, because it provides a table in the guidance that really is a nice algorithm for you to determine, okay, my resident has an MDRO, it's contained or it's not contained, they're colonized or they have active infection, do they stay in isolation or do they come out of their room? And so I really encourage you, first and foremost, to download the guidance so that you have it and you can follow that table. It's going to help you significantly understand when to apply the enhanced barrier precautions for which residents and when not to. You can stay on that slide. Sorry, Jenna. So we want to we want to implement the enhanced barrier precautions for residents that, and this is tricky for people. It's kind of hard to put our brain around this, myself included at times, is if they have an infection, it can potentially be an active infection or colonization with an MDRO when contact precautions would not otherwise apply. We want to implement it with wounds and or any indwelling medical devices. We're talking IVs, catheters, PEG tubes, any type of indwelling medical device, regardless if they have an MDRO or not. This is the tricky part where it kind of stumps people. And then, as I said, it's not limited to outbreaks or specific MDROs. And that's the biggest change here, is that we're actually implementing it for the residents who don't have an MDRO. And we'll talk about that a little bit further. All right, next slide, please. So also on the CDC website, they have this great signage. I highly encourage you to download it, print it, laminate it. It's different than what contact precaution signage looks like, what droplet precaution signage looks like, what enteric base precautions look like. And I think it's important that we have this differentiating sign so that the staff become used to identifying what this means and the difference and why we're using, and that it's actually a different protocol. So the actual guidance is to use a gown and gloves during high contact resident care activity. No private room is required. Residents can participate in group activities. That means they can leave their room, they can go to dining, they can go to activities. And the key to this is it's intended to be used for prolonged periods of time. That means that it can be used for the entire length of their stay. Next slide, please. And so many times when myself or my staff, we come on site or we're presenting this information, one of the first things in long-term care, many times we want to know, is it required? Are the surveyors citing us for it? Is it part of our regulatory requirements? And I always lead with this. First of all, we want to implement enhanced barrier precautions because it's the right thing to do. As you saw with the research, as you saw with the global impact of antimicrobial resistance, that we know this is an urgent threat to our communities, to our state, to our nation, to our globe. And we need to make sure we want to do our part and we want to implement these best practices to prevent the harm. And we always want to follow the regulatory requirements. And so what I say to people in our F880 infection control regulations, you see here that for our infection control program, it says that we have to, implement these practices based on, many different elements. But I want to draw your attention to what it says in red. And it says that the facility should ensure that current infection control standards of practice are based on nationally recognized standards and guidelines. And what that means is our surveyors, our regulatory CMS, they want to make sure that we are abiding by our public health standards and regulations, or not regulations, but standards and guidance. And this is enhanced barrier precautions falls under that. So technically, I mean, it very well could just fall under that in and of itself. So I just want to draw your attention to that, and we'll talk a little bit more as well. So next slide, please. So I always want to equip you with the information so that you have what you need for the federal requirements. And if you go to the CDC, or I'm sorry, the CMS downloads for our surveys, you can actually see Appendix PP actually has information regarding enhanced barrier precautions located in that. And then under the survey resources, it also has information as well. Next slide, please. You can actually download by following the path that I just described, you can actually download the LTC survey pathways, and this will help you to have all of the current and updated guidance or regulations regarding any of these protocols. Now, what it actually says in Appendix PP related to enhanced barrier precautions, it actually talks about implementing enhanced barrier precautions. It's more of the old language that refer to colonized residents, but interestingly enough, they have the link to the current guidelines. So I'm just presenting you with what CMS has on their Appendix PP and this information, and then you can interpret that the way you choose. I do know of facilities that have been cited for not implementing enhanced barrier precautions. And so again, I don't want to lead with, we want to do it because we could get cited on it. I tell you this because we want to always be following the best practices and, of course, being in line with our federal regulations. Next slide. Okay, and so this again is if you are new to long-term care, or you haven't or you need to update your infection control policies and practices, I always recommend that you download. This is actually the pathway. The 20054 is the pathway for infection prevention and control, and what surveyors are going to look at in your facility regarding your infection control practices. And as I said, it states in there that MDROs refer to microorganisms, predominantly bacteria. It goes into talking about what MDROs refer to. And like I said, it provides the link to the enhanced barrier precautions and states for us to follow those recommendations. Okay, I think I've drilled this in enough, so we'll move on. So let's talk about, I'll just, as a side note, like, I have so much trauma from COVID and how much we were cited from during our COVID pandemic that, I'm always like so protective and want to make sure that that we're following everything regulatory wise. So that's why I always include it. So let's talk about how we implement it. Have any of you on the call today implemented the enhanced barrier precautions in your facility? I would love to see if you guys have implemented this. And I'd like to know two things. Number one, what has gone well? And number two, what is one challenge that you've had? And so I'll just take a quick pause to see how that's working for you.
I am not seeing anything in the chat yet, Dr. Buffy, but I'm not sure if everybody can see the chat option.
Okay.
Or if we're seeing question and answers coming in. So Diane, if you would like to unmute and read those questions for us, that would be wonderful.
Sure. So we got a couple questions asking for the PowerPoint, which I've provided. There was a question asking for a link to the guidance, the table specifically that you referenced. I think there was a link at the bottom of that slide to CDC, but we can try and provide the link directly to it. We have one participant who said they have implemented enhanced barrier precautions.
Okay.
That's all I have so far.
It looks like the chat may be disabled. I'm not really sure, so we'll want to.
Yeah, I think it's because of the format that we're using for the webinar today.
Okay.
So, yep.
So if you can put it into question and answers, then we'll be able to see it, and then I can read them to Buffy.
Perfect. So the Q&A is where we need to go. Got it. Okay, so let's put it in the Q&A, not the chat. All right, sure. Thank you.
So I have another question here from Justin. We have implemented enhanced barrier precautions, but our staff is wondering why hospitals are not also implementing them. So that's a common question. Perhaps you can address that.
Yeah, I actually, so I was talking with a nurse at one of the long-term care facilities recently, and she said like she had a family member who went to the hospital and they had an MDRO, and she was like, you have to put them on enhanced barrier precautions. And they looked at her like, what the heck are you talking about? And I said to her, I said, well, that's because hospitals don't implement enhanced barrier precautions. And why is that? We don't, because in a hospital, if a patient has an MDRO, colonized or infected, what's the guidance? They have to stay in their room on isolation for the duration of their stay. So it's actually more restrictive in the sense of they have to, they're not allowed to come out of their room at all. And that's why enhanced barrier precautions really was developed, because that actually was also our original guidance years ago. And well, that's not appropriate for our setting. We can't keep our residents in isolation for the duration of their stay. They could be staying there indefinitely. However, I do think there could be some potential changes in the future, because, you know, if we talk about the silent spreading of MDRO colonization, and to wear gown and gloves for any resident that has an indwelling device, then we could argue that that would be helpful in hospitals as well, right? Because then because if it's silently spreading in long-term care, well, it's most likely silently spreading in hospitals as well. But as of now, it's not, that particular piece is not, that's, you know, for our long-term care, given again the duration of how long our residents are staying with us. And that's why the risk is much higher.
And I know, Dr. Buffy, that I've read that the isolation guidelines are currently under review. So it will be interesting to see if there are some changes related to this for the hospital setting. A couple other questions that are comments that have come forth. Education is the key, having the staff buy-in, especially important to explain the reason why, as you've done, you know, the science behind it. Some of the complications people have noted are the cost of PPE supplies, as well as family resistance to having their loved one in transmission-based precautions. Another comment we implemented last year and going well, but would love to find a way to make it look less institutional as we promote a home-like environment. So if you could kind of speak to some of those concerns.
Yeah, so let's we'll go into more of, and there's a lot more of those in the Q&A, so keep those coming, you guys. That's great. And I'm going to go into some of those as we progress through the slides, and that'll answer some of these questions as well. So we'll go ahead. So the implementation of the enhanced barrier precautions is, like I said, it is for those residents that have a known colonized MDRO, or potentially even an active infection where they're not on contact precautions. Now, here's the key. If they have acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be covered or contained, then this is when they would stay in their room on isolation. And then if none of those are present, then the enhanced barrier precautions typically is appropriate just based on our everyday management. So we'll get into that as well. So next slide, please. And also for the individual talked about the link to the table, it's actually when you go to the enhanced barrier precaution information on CDC, I would download the whole guidance, because the table is in the guidance document. I think it's like 6 pages. And so as we talk further about the guidance advises us, like for the care and the use of indwelling devices, and then how is this defined. And so basically, again, if somebody has any type of indwelling device or major risk, or they're colonized, then we would advise them to wear a gown or gloves for any care that such as, this is gown and gloves for what's considered high risk activities such as dressing changes, high risk nursing activities, injections or infusion medications or tube feeds. And then also for other contact that you may have, such as like transfers and things such as that. So the CDC does recommend bundling practices together as a method of reducing the high usage of personal protective equipment. And so as much as possible, being able to, come in and do all of those high nursing activities at the same time versus maybe coming in 5 different times to do that. So that is one strategy the CDC does recommend. And I am curious if anybody does that or has taken that into effect and implementing that as well. Next slide, please. So the wound definition is defined as, they have a wound. So all the residents with wounds would meet this criteria. And then again, it would be focused on those that have, MDRO for a long period of time. So if you have even a resident that has an MDRO in the wound, if it's contained, then again, they don't have to stay in their room isolated. And that's something that changed because if it was, it was a lot of times, and I still get these questions every day, like, how can we, the doctor says they have to stay in the room isolated for the duration of their stay. They have their, MDRO in their urine or something like that. And so we have to, really understand that if it's contained, then they don't have to stay isolated in their room. And then also, so generally, as you see here, residents that have chronic wounds that not only those with shorter lasting wounds, but such as skin breaks or skin tears, covered with Band-Aids and similar dressing. So that's not, those are not really considered that type of wound. So it's more talking like pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, and such like that. Next slide, please. And so we talk about implementing gown and gloves for even like, this was a question that came in, like, should we do it when we're showering a resident? So it is recommended for the residents, if any transfers or assisting during bathing, to wear the gown and gloves, and of course, hand hygiene. And this has created quite a challenge. And again, the reason we want to make sure that we're doing this is so that we are protecting those residents from potentially us at this point. That's what's so different about enhanced barrier precautions is we're not like, they don't have an infection, or they may not have an infection, but we don't know what we're silently spreading with our hands, with our uniforms. And so this is why we want to protect them. And a simple way to look at this as well is most of these activities, you would be wearing gloves as standard precautions anyway. And so now we're just asked to put on a gown as an additional precaution. And so if you kind of look at that like, well, okay, it's one extra step of protection, but it's really, again, more towards protecting the resident from us, because we don't know what we may have that could be able to be transmitted to them. Next slide, please. And again, we're going to, this was a question that came in, are gown and gloves recommended for enhanced barrier precautions when transferring a resident from a wheelchair to a chair? And actually, this is not recommended as far as like when they're going to the day room or dining room. So this actually came from the CDC. We had reached out to them and they said it's not recommended when performing those common transfers such as dining or activity room, where that activity is considered, it's a shorter duration. But it's primarily intended to use when there's high contact resident care activity. So just kind of keeping that in mind and differentiating that will help. Next slide, please. And so linens, we talk about what should we do about the linens, and linens should be handled. We always like, do they have to be treated differently, or are they the same? And basically, we want to just treat all linens as if they are potentially contaminated. And so there is no special handling of them or labeling, and there are no special, we don't have to treat that linen any differently. But you also want to make sure that your laundry is set up to actually treat the soiled linen as it is contaminated. And so that's really important as well. Next slide. And so we talk about the importance of implementing, implementing enhanced barrier precautions it's not the answer for everything. It's part of a broader plan of being able to reduce the risk of those MDROs that include hand hygiene, include environmental cleaning and disinfecting, include now the addition of enhanced barrier precautions, include auditing our practices, and include communicating with our healthcare partners, our hospitals, when we're admitting residents. How well documented are those MDROs? And again, we can't fully rely on what is documented, as we need to be able to because of the silent spread, because we saw in the research that it's not just based on that there's so much that's undetected. And so as part of a collaborative approach, take into account how are these other programs. And I encourage facilities to really start slow with all of this. And so start with maybe those that are colonized, start with those residents, or maybe even start, just starting slow is going to help. As somebody had mentioned in the Q&A, it's very important to educate our staff on the difference between isolation and enhanced barrier precautions, because it's very different and it's very backwards from the way that the way we're thinking. And so some of those best approaches are, having your staff teach you, okay, tell me why we're doing this, and really having them teach you about it, I find helps hardwire it for them better. Next slide. So here's some additional resources for you. And so this, the first bullet is the implementation. That's the link is actually the link that you can go to download the what I'm talking about, the guidance. And then in that guidance is the table. And then the next one is the frequently asked questions. I think that's really important, and it's going to address a lot of those questions that you have. The next ones are like, there's a letter to nursing home residents, families, and friends to help with your education practices. And there's a letter to nursing home staff as well. And so these tools will be able to support you as you continue to implement these practices. So I think that's the next slide is probably just for questions. And so we can answer more of those questions in our Q&A.
And Dr. Buffy, your audio is getting a little scratchy. If you can again come closer to your computer, that worked great before. A couple specific questions in the chat. Would a Metaplex wound dressing be similar to Band-Aid and not require enhanced barrier precautions?
So yeah, it's just something that's covering, lightly covering the skin. Then that wouldn't require it.
Great. Could you speak a little bit to the need for enhanced barrier precautions in a vent unit, please?
Yeah, so this is one of those areas. Can you hear me better?
Yes, thank you.
Okay, so this is one of those areas that if you haven't implemented enhanced barrier precautions, I would highly recommend that you start here. As we saw in that research, the risk is so much higher in a vent unit. And so really, a lot of times your residents are going to be, again, your staff are, in addition to wearing the gloves for most of the care that they're giving, now we're just asked that they put on a gown for that care. And so that's going, again, to help protect the residents from whatever we may be transferring with our hands as well as our uniform. And so it's really no different as far as the implementation practices. It may require more resources as far as gowns. But yeah, you definitely want to implement it for all of your vent residents because that is the highest risk. And as we saw in the slides, that when in the research, when that nursing home was, when they tested the residents, there was, nearly all of the residents in the vent unit actually were colonized with that MDRO. So that was really important research to see the higher risk residents like that.
Awesome. Another question, could you speak a little bit about how an MDRO infected or colonized resident actually spreads the organism or sheds the organisms? If they don't have an active draining wound, how is it being spread? Can you speak a little bit to that?
Yeah, it's actually spread through, it can be spread on our skin, our hands, the environment. So it's mostly many times people will say like we have like MRSA like on our skin. And so it is something that could even, it could be shed in the urine and stool. And so that's why it can be in the environment. And so that's why it's so important that we have strong hand hygiene practices and environmental cleaning practices. We spend so much time when we're on site evaluating environmental cleaning practices because the bacteria, the fungus, the viruses can live, longer on those surfaces. And so it's really through the environment a lot that is spread, which gets there by our hands, right? And our
Absolutely.
uniforms.
Have there been any studies that show that enhanced barrier precautions has actually reduced the spread of MDROs? I'm not sure it's been implemented long enough to really have studies to show that. But yeah, that would be great to have that kind of study to be able to share that with our staff and certainly help them understand it. Can PPE be kept in the residence room or should it be outside the room door as we're used to?
Yeah, so that's a really good point. The CDC actually in the guidance does recommend having it placed outside. And this was one of those areas where it's different than isolation. And so I would really, evaluate that within your team. And we want to follow what the CDC says, but I'm not, I think that it potentially could be in the room in a way that's discreet. And I've actually seen this where this helps to where it doesn't have that institutional look. When we've got PPE bins, what is that? In our brains, we're hardwired to know like that person has an infection, right? Like that's what we've trained ourselves, we trained our staff, we've trained our visitors, we've trained our clinicians. When they see the PPE bins, they have an infection. And so I do believe we have to do this a little differently. And so just like you could potentially keep clean linens in the room, like, as long as they're covered, it is possible, I believe, to keep the clean PPE. I think you just want to make sure it's, of course it's clean, but you want to make sure that it's covered is what I was trying to say. And so that it stays so it doesn't get contaminated. That's the biggest thing. And I think if we did that, I do believe it would help reduce kind of the drama around it, I think, and make it more of a normal practice where like we keep gloves in the rooms, right? So I just think if we look at it in that perspective, then I think it kind of takes away this that it's a big deal, like we're going to put gloves on anyway, we're going to throw a gown on as well. And it may help with reducing the institutional feel with all of it while keeping the residents protected.
Yeah, I would totally agree with that. Another question. When is a resident considered to not be colonized, or are they colonized, forever once they're colonized?
Yeah, I mean, so the other thing I didn't mention today is, one of the strategies and that we're not going to do is we're not going to test everybody for an MDRO all the time, right? Like that's not something we do. And so again, it really doesn't matter if we think about it in the sense of how long somebody is colonized or not. And that's really subjective. We may not know that because we don't test. And so this is why we're implementing this practice, whether a resident is known to be colonized or not. And that, because as you saw with the research, if over 50% of residents are potentially colonized based on the research, then we just have to assume that there is a risk there. And so, that's why we want to implement these practices all the time for those high risk residents. And keep that in mind. Again, it's those residents with an IV, it's a residents with the catheter, and only during those high risk the higher nursing activities as well.
And can you speak a little bit to potentially how residents who are sharing a bathroom, so even if in a private room, but a shared bathroom, and if one of the residents is on enhanced barrier precautions, how should that be handled?
Yeah, and this is a great question. And again, this is where we really differentiate between somebody with an active infection and somebody that is on enhanced barrier precautions. I really want us to start thinking of it more as just standard precautions. And so if you had residents that were sharing a room and you needed to wear gloves, then that it wouldn't matter, right? Like it doesn't matter if they're sharing a room, if they're sharing a restroom, because again, that resident is not, now if they have an active infection, that's different. But if we're just doing this based on an indwelling device, then that other resident, like we don't know if they're colonized or not. And so the main risk is with our staff, right? Is with and with if they're using the same restroom, again, making sure those good house cleaning practices are implemented and in place. That's going to be the biggest indicator for that.
Can you clarify unhealed surgical wounds? Does that mean all surgical wounds, since a lot of our residents come to us from the hospital after surgery, or is it that they haven't healed within the normal expected time frame?
So actually, the guidance doesn't actually state healed or not healed. It just says wounds, and that's probably why you're asking for the clarification. What's more important to how to implement this is based on, well, if the wound is healed, then they wouldn't be considered to have a wound anymore, right? If the wound is not healed, you're still treating it, and it can be covered, then again, that's we're still wanting to implement enhanced barrier precautions. If it's healed, yeah, no, you don't need to, there's nothing more that you need to implement with that. But again, if it's not and it can't be covered, then they do have to, if they do have a colonized MDRO, they would have to stay in their room as well. So there is a little bit more with that, but I think the key takeaway is, as far as just enhanced barrier precautions, we don't know if they're colonized or not. Then we would want to, if they don't have a wound anymore, it's healed, then they don't have to be on the enhanced barrier precautions, as long as they don't have an indwelling device as well.
Question, is there a list of all the MDROs available that we should be concerned about? I know that the CDC is listed on their website. The State Department of Public Health for Wisconsin also has them listed there.
Yeah, and I really highly recommend you going back to where I initially took you, where the CDC website. They actually, what I love about the guidance they have there is they actually will even, they tell you what microorganisms or MDROs are actually an urgent threat, a serious threat, and what other MDROs they're keeping an eye on. And then again, they have such detailed information about treatment and transmissibility and all of the information about the particular MDROs that you could fill up. I mean, there's just so much there that's a one place that you can go as well to get that information. And like Diane said, one of the things that's really important, I just want to emphasize, if you have an outbreak of any of these MDROs that are the emerging pathogens, such as C. auris, we've done a lot of presentations on this recently. You please make sure you're working with your public health, your epidemiologist, because this is where, it actually says in the enhanced barrier precautions that you could potentially have an active infection and still be on enhanced barrier precautions, and you don't have to be isolated in your room. The caveat to that is that you need to be working with your public health teams to make those decisions. And so when you are faced with an outbreak of one of these emerging pathogens, it's really important that you're working with your public health to get the guidance and direction, especially when it comes to testing, retrospective testing and all of that. It's very important to work with your health department on that.
Comment in the Q&A just on the challenge of implementing enhanced barrier precautions. Once the volume becomes so great, this particular facility feels that, like a third of their residents potentially qualify for being on enhanced barrier precautions. And we do recognize the challenges that could bring. Do you have any other comments in regard to that?
I think that's the most significant challenge, I would say, apart from educating, because the education is also quite significant in understanding when to implement this, especially for our floor nurses and whatnot. The PPE challenges, again, I talked about, and I don't know if anybody's doing this. I'd love to hear if you guys are, but the CDC does recommend, bundling those practices together. Again, I don't know how practical that is, and I don't know if anybody's actually doing that, where okay, I have to go into this room and I have to do all these different activities. And maybe instead of going in 3 or 4 different times to do them, I'm just going to go in and do them all at the same time. So again, you're the best. You can teach us if that is actually working or not. And then also keep in mind, and so the signage that I listed, it actually states on there when it's indicated for wearing the gown. And so remembering to educate the staff that it's not all the time. It's not like if you're just passing meds or, it's not for everybody all the time. And so it's really just, I think if we can understand when to wear the extra gown and not, of course, the gloves, then that may help as well. Rather than, I know some facilities are just do it all the time because my staff don't remember when, and it's easier to just do it all the time. So, just try different things. But I think that really having an understanding of, when we have to, or when it's recommended based on the risk, will help us to really hone in and hopefully, there's no way around it. You're definitely going to burn through more gowns than you would otherwise. There's just no way around that. But maybe trying some of those, so those other maybe trying just bundling and making sure that it's just done when it needs to will help.
And sort of an add-on question, when you were talking about the increased use of gowns, we certainly recognize that is going to be a factor. Can a staff member use their own reusable washable gown for one resident for their shift? And could you just kind of talk about the dangers of doing that? So could you kind of give the rationale so that we can explain to our staff, why that is not an option?
Yeah, so if we think about the purpose of why we're doing what we're doing, then if we did that, then there's no point in us doing it at all. Because the whole point of us doing it is to protect that resident from what we may have on our uniforms or our hands, right? And so if we're reusing anytime, first of all, we never want to reuse any PPE unless we're in a crisis, which we all know we had to do in COVID. But whenever we reuse any PPE, think about the gown. When we go to grab that gown and put it on, we are potentially recontaminating ourselves or that that gown. So if we're taking it off and putting it back on and then putting it off, then whatever we may have on our uniform may end up getting on there, and that may end up getting on the resident anyway. So it just doesn't make sense to reuse it. There would be no reason to even use a gown at all, because we're trying to have a clean surface on our body, basically, to protect the resident from getting any germs that may be living on our uniforms. That's the reason.
Thank you. And I think you've done a really great job for us today on sort of explaining some of these gray areas, because I think that's where the most, questions are, certainly. Another comment that it's not only the PPE that gets expensive, but having to have enough isolations, PPE carts, and the covered linen and trash cans. And so we do recognize that, this is something that, again, is something, increased supplies. You're going to have to gradually build up that supply to get there. And I think to your point of starting somewhere to, what is your biggest risk factor in your facility? Where should you start the implementation process if you haven't gotten it completely implemented?
Yeah, and I would, like we said, I would start if you have a vent unit, I'd start there. I'd start with the known colonization. So start there, get the staff used to that. And then, slowly start with maybe even just one hallway. I mean, we really have to it's going to take time. And that's why, kind of going back to the survey process, I'm like, let's not wait until the surveyors are citing. Like, let's take this time to start implementing it and putting it into practice before it becomes something that may be cited, because then to implement this quickly is going to be very difficult. And so to implement it slowly over time is going to set your facility, your residents, your staff up for the greatest success.
Definitely. I really want to thank our participants for being so involved in sending in all these great questions for us. I'm sure that if there's any questions that come up after today's talk, they can either get a hold of you or they can get a hold of us, and we will contact with you. But any final thoughts, Buffy, as we're kind of wrapping up?
Yeah, before the call, I said to Diane and Jenna, I said, how long do we have? Because we could probably talk about this for hours, and maybe there will be a follow-up that maybe we need to. I don't know, because it really is industry-wide still a big challenge. And so, first of all, thank you for showing up today. Thank you for taking the time to participate and learn more and being engaged with your residents and your facility to learn more. And I know it can be a challenge. And so thank you for, equipping yourself with more knowledge and understanding. We're here to help you through this process. Superior Health, IPC Well, like, we are all here to help you, whether you want an on-site visit or you need help. We're all here to help you implement this the best that we can. So thank you so much for participating. And I'm just so grateful that you showed up today.
A couple more quick questions. Are there any sample policies available? And I believe there are links to that on the CDC resources that you shared. A specific question about methicillin-resistant staph epi, so not MRSA, but MRSE. It is not on the list of, sort of the most common MDROs that we're concerned about,
Right.
But do you have any thoughts specifically on MRSE?
I would I don't have any specific about that particular organism, but what I would say is we just want to implement this broadly across all of them, because it's going to impact it all matters, right? So it doesn't matter really what organism it has. We really want to treat it the same in that regard. So as far as enhanced barrier precautions goes.
Well, I really want to thank you, Dr. Buffy, for speaking with us today. I don't think I've ever seen this many questions come in during a webinar, so that just speaks to the complicity of the issue, the reason we wanted to have you talk to our folks. And certainly as things change and as things evolve, we'd love to kind of perhaps revisit it again with you. And any final thoughts, Jana?
None, but just to emphasize Diane's statement. Thank you, Dr. Buffy, so much for this. This is a topic that we probably field so many questions on, and there's so much gray space with it. So you really helped, I hope, our audience understand it a little bit better and kind of give them a starting off point if they've not started yet on how to get started and those great resources from the CDC. So thank you again.
Yeah, you're welcome. Thank you.
And I'll just put my contact information in the chat for any questions that come up, and we can certainly get them to Dr. Buffy.
Absolutely. And thank you again for attending. For future events, if you would like to go to the Superior Health Quality Alliance webpage, on that page, there is a link to sign up to connect with us via email to be updated on upcoming events. We look forward to seeing you in the future. In 2024, we will be starting our new nursing home roundtable series, and that series will include an FTAG specific grouping of educations related to the top cited FTAGs across our region. So we're looking forward to kicking off 2024 with topics that you all have identified as needing more additional information. So thank you again, everybody, and have a great rest of your afternoon.